Obsessive-compulsive disorder operates as a rigid, self-reinforcing loop. It generates intense psychological friction, forces a behavioral release, and then aggressively resets itself. To understand how to stop it, we have to deconstruct the specific clinical architecture of this disease. Clinically, OCD is a psychiatric disorder characterized by a self-reinforcing pathogenic feedback loop. This schematic isolates the two variables driving the pathology, the intrusive cognitive phenomenon on the left and the rigid behavioral response on the right. These variables feed directly into one another, generating escalating psychological tension that traps the patient in a continuous cycle. The entire scope of clinical management revolves around this structure. Diagnosis relies on confirming the presence of this specific loop, and treatment requires disrupting its nodes. Approaching OCD simply as a checklist of symptoms often leads to misdiagnosis. Viewing it as a mechanical system provides the structural logic necessary for effective intervention. In a clinical setting, dismantling this system begins with a thorough patient history and mental status examination. Both the DSM and ICD require a strict diagnostic baseline, the explicit presence of obsessions, compulsions, or a combination of both. Brief intrusive thoughts or occasional double-checking are normal human experiences. To cross the threshold into pathology, these symptoms must be highly time-consuming or cause significant functional impairment in the patient's daily life. A defining hallmark of this impairment is that the pathology is usually ego-dystonic. The patient recognizes that the symptoms are unwanted, deeply distressing, and separate from their actual desires and personality. Finally, the clinician must rule out external factors. The symptoms cannot be better explained by another psychiatric disorder, a distinct medical condition, or a substance-induced state. Establishing this baseline ensures the physician is targeting a primary, Axis 1 disorder, rather than chasing the secondary symptoms of a different condition. Before we assemble the complete loop, we have to define the strict clinical parameters of its two core components, starting with obsessions. Obsessions are recurrent, persistent thoughts, impulses, or images that aggressively intrude into a person's consciousness. These manifest in highly specific ways. Common clinical presentations include severe fears of contamination, intense anxieties about harming oneself or others, overwhelming needs for exact symmetry, or highly distressing sexual and religious imagery. A critical element of insight usually remains intact. The patient recognizes that these terrifying intrusions are being generated by their own mind, not implanted by an external force. That internal distress dictates the second half of the pathology, the compulsions. Compulsions are repetitive behaviors or mental acts executed strictly in response to the obsession, often following rigid, idiosyncratic rules. These can be observable physical actions, like excessive hand-washing, arranging objects, or repeatedly checking locks. But they can also be covert mental rituals, such as silent counting, mental praying, or repeating specific words. The compulsion serves a singular mechanistic purpose. The patient performs the ritual to reduce their overwhelming anxiety or to prevent a feared catastrophic event. Neither intrusive thoughts nor repetitive habits alone constitute clinical OCD. The disorder exists in the pathological dependency between the two. This 5-stage circular flowchart models the complete sequence of the pathology as a closed-loop system. The cycle triggers when an obsessive thought enters the mind, immediately spiking the anxiety and distress node. Unable to tolerate the overwhelming distress, the patient resorts to a maladaptive response, which forces the execution of the compulsion. This achieves an immediate neurobiological result. The compulsion serves as a relief valve, providing temporary relief and bringing the distress levels back down. But this creates a critical failure point. Because the relief was achieved through a rigid rule rather than natural habituation, the brain reinforces the behavior. This ensures the obsession will return, usually with greater intensity. As this accelerating cycle takes hold, the clinical fallout is severe. Patients develop extreme avoidance of situations that trigger their obsessions, suffer from disrupted concentration, and experience profound sleep disturbances. Because the rituals must be repeated until they feel just right, they consume hours of the day, causing significant impairment in academic studies, careers, and interpersonal relationships. The ultimate tragic irony of OCD is that the very act of seeking relief through a compulsion is what guarantees the disorder's chronicity. A frequent error among early career clinicians is conflating severe, rigid perfectionism with true OCD. This requires evaluating a primary differential diagnosis, obsessive-compulsive personality disorder, or OCPD. This split-screen comparison table establishes the strict diagnostic boundary between the two conditions. Looking at symptom nature, OCD is characterized by specific, intrusive obsessions and the resulting rituals. OCPD is characterized by a generalized, pervasive pattern of perfectionism, orderliness, and control. The most crucial distinction relies on insight. OCD thoughts are ego-dystonic, experienced as intrusive and unwanted. OCPD traits are ego-syntonic, experienced by the patient as justified, appropriate, and correct. Anxiety is highly prominent and overwhelming in OCD, driving the rituals. In OCPD, baseline anxiety is generally far less prominent. Both cause significant life impairment, but the mechanisms differ. OCPD damage primarily stems from interpersonal friction caused by the patient's rigidity. OCD damage stems from being trapped in a debilitating, time-consuming loop. Correctly identifying this boundary is vital. Attempting to treat an ego-syntonic personality disorder with a behavioral algorithm designed for intrusive obsessions results in a mismatch of clinical rationale, as the underlying drivers of the behaviors are different. Once an accurate diagnosis is confirmed, evidence-based medicine targets specific vulnerabilities within the pathological loop. Returning to our 5-stage model allows us to visualize exactly where these treatments strike. The first-line behavioral intervention is a specific form of cognitive behavioral therapy, known as exposure and response prevention, or ERP. In ERP, the clinician intentionally exnuses the patient to the feared stimulus, spiking the distress node, but they then strictly prevent the patient from executing the compulsive response. By blocking the compulsion, the patient is forced to remain in the distress. Over time, the brain naturally habituates to the anxiety without needing the temporary relief, ultimately breaking the loop's behavioral reinforcement. This behavioral intervention is paired with first-line pharmacological treatment, selective serotonin reuptake inhibitors, including fluoxetine, fluvoxamine, or sertraline. SSRIs chemically lower the baseline intensity of the anxiety and distress node, making the rigorous ERP exercises tolerable enough for the patient to complete. A critical psychopharmacology pearl for clinicians. Achieving efficacy in OCD requires significantly higher SSRI doses and a much longer treatment trial than when treating major depressive disorder. Standard therapy, therefore, is a dual-pronged attack: chemical dampening of the anxiety node combined with a strict behavioral block of the compulsion node. In clinical practice, standard ERP and SSRI combinations are sometimes unsuitable or yield a partial response. When this occurs, clinicians utilize a secondary psychopharmacological option, clomipramine. Clomipramine is a tricyclic antidepressant with exceptionally strong efficacy in OCD. However, it is relegated to second-line status because its adverse effect profile is heavier than that of modern SSRIs. For highly treatment-resistant patients, psychiatrists may deploy augmentation strategies, like adding an antipsychotic medication. This specific augmentation is clinically indicated for patients who show poor response to standard treatments, or when OCD presents alongside specific comorbid features, such as tic disorders. Managing treatment-resistant OCD requires escalating through therapeutic algorithms while balancing clinical efficacy against adverse side effects. Obsessive-compulsive disorder is an architecture of intrusion, a relentless, time-consuming loop of distress and reaction. To dismantle it, clinicians must first execute a precise differential diagnosis, separating ego-dystonic suffering from the justified rigidity of personality traits. Successful management depends on systematically breaking the cycle through targeted ERP exposure and robust SSRI dosing. It is a structural failure of the mind's regulatory systems, but with precise clinical mapping and targeted disruption, the engine of distress can be